I'm Becca Edwards, and I'm a second-year ophthalmology resident at the University of Colorado. I went to Northwestern for my medical and graduate training, and I hope to become a physician scientist when I've completed my ophthalmology residency. I was interested in gaining experience in translational and clinical research during my residency, as my PhD research was very basic science focused. The clinical project that I would like to discuss today is in the area of uveitis. Uveitis is a group of conditions involving inflammation of the tissues of the eye that are supplied by blood vessels, including the iris, ciliary body, and choroid, along with neighboring tissues including the retina, vitreous, and optic nerve. This inflammation may be caused by infection, be associated with systemic diseases, including a variety of autoimmune conditions, or occur in isolation. Uveitis contributes to an estimated 5 to 10% of global vision impairment, and 35% of patients with uveitis develop significant vision loss or blindness. Over 40,000 new cases of uveitis are diagnosed in the U.S. each year. Many of these are chronic and relapsing, and unchecked inflammation in the eye is associated with vision-threatening comorbidities such as glaucoma, cataract, and retinal problems. Average costs for non-infectious uveitis patients range from 3.1 to 8.3 times the cost of the average privately insured patient, reflecting the frequent use of the healthcare system by these patients, the prolonged nature of medical therapy, and common need for surgical interventions. According to this study, these average monthly costs supersede those of patients with hypertension and diabetes and are similar to those of some cancer patients. Fortunately for patients with uveitis, a variety of medications developed for the treatment of other autoimmune conditions have proved useful in the treatment of non-infectious uveitis. These immunosuppressive agents decrease the abnormal immune response in some forms of uveitis. One of the most powerful medications at our disposal are corticosteroids, which are strong suppressors of the immune system. The problem with steroids is that they have many side effects, both on the entirety of the body if given systemically, and on the eye if given in drop or injection form. For example, steroids can cause the pressure inside the eye to rise and hasten the onset of cataracts. For this reason, other medications which avoid steroids, so-called steroid-sparing agents, have been tried in uveitis. But it is not readily apparent from the existing literature which agent is best to use when. We are using a meta-analysis approach to compare randomized controlled trials of steroid-sparing therapies in a specific subtype of uveitis, with the very snappy name of non-infectious, meaning not caused by infection, intermediate, posterior, and pan-uveitis, meaning the inflammation affects the structures in the back of the eye. Meta-analyses are studies which aggregate data from many independent, smaller studies in order to understand broader trends. Rather than having to make judgments on every individual study in a body of literature, clinicians may rely on high-quality meta-analyses to provide a global understanding of a specific clinical question. Cochrane reviews are a collection of systemic meta-analysis-based reviews that are internationally recognized as the highest standard of evidence-based information in healthcare, and this project is registered as a Cochrane review through Cochrane Eyes and Vision. Our main objective with this meta-analysis is to compare the efficacy and tolerability of select steroid-sparing non-biologic agents, specifically methotrexate, mycophenolate, tacrolimus, cyclosporin, and azathioprine, in the treatment of active, non-infectious intermediate, posterior, and pan-uveitis in adults. We are currently in the process of collecting the raw data from all the relevant studies that have been done up to this point. This data will then be reanalyzed by myself and our statistician so that we may determine which medications are most effective. We are looking at a variety of outcomes, including a number of measurements of control of inflammation, improvement in the patient's vision, ability of the patient to be weaned from steroids, and the proportion of patients experiencing adverse effects. We are also looking at patient-reported quality of life measurements and cost effectiveness, using the incremental cost-effectiveness ratio. Our proposed protocol is currently under peer review within the Cochrane organization, and once approved, we anticipate a completed meta-analysis within a year. This work is important because, like uveitis itself, the data and trials in uveitis have been varied, and it is hard for physicians and patients to know how to compare the results of the different trials. These drugs are used widely in the US and the world, especially in developing countries where the costs of newer classes of medications, called biologic therapies, are prohibitive. Ultimately, we hope to provide a set of recommendations that clinicians around the world may turn to for guidance in the care of their patients with uveitis. If we can make recommendations about which drugs are best to use, we can increase the efficacy of our therapy, hopefully at a lower cost, thereby increasing access. Thank you.